Hello students, myself Dinesh, Assistant Professor, Department of Anaesthesia Technology, School of Allied Health Sciences, Salem. So today we'll be discussing on a topic perioperative fluid therapy. So first we'll be discussing about the definition. So fluid therapy is the administration of fluids to maintain or restore normal fluid and electrolyte balance, circulatory volume and tissue perfusion in the body. So mainly we have the three aims to discuss. One is to maintain the fluid and electrolyte balance. Next thing is to maintain the circulatory volume, and last thing is to maintain the tissue perfusion. So these are the three main aims to maintain in the fluid therapy. It forms a key component in the perioperative and critical care management. So coming to goals of fluid therapy. So what are the goals of fluid therapy? So first main goal is to maintain the euvolemia. Euvolemia means it is not a hypovolemia or hypervolemia, to maintain the normal volume in the body. Then maintain the intravascular volume and cardiac output. So third goal is ensure adequate tissue perfusion and oxygen delivery to the body. Then fourth is correct fluid and electrolyte imbalance. And last is replace the ongoing losses like surgical losses, insensible losses and gastrointestinal losses like vomiting, diarrhea, constipation. So these are the main replacing ongoing losses. So these are the five main goals of the fluid therapy. So next we'll be discussing about the types of body fluid compartment. So before going to the concept of fluid therapy, we'll be discussing how the body fluids is divided. So first, a total body water is approximately 60% of the body weight. So when we see this image, so we'll be getting to know. So total body weight is divided into two, that is fluids and solids. So fluids is around 60% and solids is around 40%. So almost total body water contains, that is 60% of the fluids. So that 60% of the fluid is divided into two, that is ICF and ECF. ICF is intracellular fluid, ECF is extracellular fluid. So ICF covers the 2/3 of the fluids and ECF covers the 1/3 of the fluids. And again the extracellular fluid is divided into interstitial fluid and plasma. And interstitial fluids covers the 75% and intravascular or plasma covers the 25% of the extracellular fluid. So this is the overall 100% of the total body weight. Okay. So this movement between the compartment is governed by stalling forces. So what do you mean by stalling forces? It is an hydrostatic pressure and osmotic pressure. So that mainly compartments between the fluid component and the body component. So next coming to indications of fluid therapy. So what are the major indications is we have main four indications, that is therapies. So first therapy is maintenance therapy, second therapy is replacement therapy, third is resuscitation therapy, fourth is corrective therapy. So maintenance therapy means it is to meet the daily requirements when oral intake is adequate. So what is that maintenance is when a patient comes to the OT or the pre-op area, at the time patient is unable to take in the oral time. At the time they will be giving through IV. So that is a maintenance therapy. Replacement therapy is to replace the ongoing losses or losses due to any situations like hemorrhage, blood loss or vomiting, diarrhea, burns, surgery. These are the major losses where there will be a fluid depletion or loss. At the time the patients will be going for hypovolemia, shock. So this will be corrected using the replacement therapy. Next is resuscitation therapy. So resuscitation therapy is mainly to treat the shock or hypovolemia, to maintain the tissue perfusion and oxygen delivery. So that terms as resuscitation therapy. Next is corrective therapy. So corrective therapy is mainly for electrolyte abnormalities, that is to manage the electrolyte abnormalities and acid base imbalances like electrolyte abnormalities like hyponatremia, hypernatremia, hypokalemia, hyperkalemia, hypocalcemia. So these conditions are electrolyte imbalances. While coming to acid basis imbalances, we have respiratory acidosis alkalosis, metabolic acidosis alkalosis. So this will be done under the corrective therapy. So these are the major four indications of the fluid therapies. So next we'll be moving on to the types of fluids, that is crystalloids and colloids. So crystalloids or colloids are the plasma expanders we use in the fluid therapy. So coming to crystalloids, so crystalloids are the aqueous solution of mineral salts and other water soluble molecules So they distribute rapidly between the extracellular fluid compartments. All these crystalloids will be distributed equally among the extracellular fluid. As we told, the fluid compartment is divided into ICF and ECF. So in that, these crystalloids will be rapidly distributed between the extracellular fluid compartment. So crystalloids include normal saline, Ringer's lactate, dextrose normal saline, and D5W. D5W means dextrose 5% water. So shortly it is termed as NS, RL, DNS and D5W. Next is colloids. So colloids contain the larger molecules. While coming to the crystalloids, contains always a smaller molecular weight. So then colloids. So colloids is a larger molecular weight. So examples of colloids includes gelatin polymers, dextran polymers, hydroxyethyl starch and then albumin. So these colloids are divided into two components that I will be discussing in the next slides. So they remain longer in the intravascular space. So compared to crystalloids, these colloids will be remaining, these have a longer shelf life than the crystalloids. So now we will be seeing the different types of crystalloid solutions. That is, crystalloid solutions types is based on the isotonic, hypotonic, hypertonic. So this is based on the tonicity of a solution. So crystalloid solutions, isotonic, hypotonic and hypotonic. Isotonic means the amount of crystalloids is equal to the amount in the plasma, that is concentration of the plasma. Here in that image we can see the isotonic crystalloid solution, the concentrate of the crystalloid solution is equal to the concentrate of the blood plasma. Hypotonic, that is concentrate of the crystalloid is lesser than the blood plasma, concentrate of the blood plasma. Then hypertonic is concentrate of the crystalloid solution is more than the concentration of the blood plasma. Here in isotonic we have the normal saline and Ringer's lactate. Normal saline, another term, it is termed as 0.9% sodium chloride solution. Ringer's lactate, it is also called as Hartmann solution, will be telling. So main uses of this isotonic solutions is it is used in the maintenance therapy and replacement therapy. So what is a note point we have to make there is it expands the extracellular fluid. As I told in the crystalloids, crystalloids are differentiately distributed all over the extracellular fluid compartments and it may cause sodium overload. Then coming to hypotonic. Under hypotonic we have the components like 0.45% NaCl or NS, then 5% dextrose, that is D5W. And after metabolism it becomes the free water. So only it is called as dextrose 5% water. It is used for cellular dehydration. Whenever the patient is dehydrated, at the time they will be administering this D5W solution. And what is a note point we have to make here is it is avoided in the raised ICP condition. ICP is intracranial pressure. Whenever the patient has a raised ICP condition, in those cases we have to avoid this 0.45% sodium chloride and D5W solutions. Next is hypertonic. Hypertonic we have 3% sodium chloride and 5% sodium chloride. It is used in the treatment of dehydration and hypernatremia. What is a note point we have to make here is it may cause cerebral edema. So this is the overall view of the tonicity of the crystalloid solutions. So these are the different crystalloid solutions. The first image we can see. So in the first image it is normal saline, then second is Ringer's lactate, third is 3% NaCl solution, and fourth is sodium chloride and glucose injection, that is only called as dextrose normal saline. So when DNS is indicated is when the patient have lower hypoglycemia conditions. So at that time to increase their glucose levels they will be using this sodium chloride with the dextrose solutions. Then we have the dextrose 5% water, that is D5W solution. So these are the different crystalloid solutions we use in our operating room as a fluid therapy management. So next we'll move on to colloid. So colloids are, as I told, it have a larger molecular weight and they are distributed in the intravascular spaces. So as you see, the colloids is divided into two types. One is natural colloids and one more is synthetic colloids. So in the natural colloids we have only one colloid, that is albumin. Albumin is available in 5% solution and 25% solution. So it is a natural colloid. So it is used in the condition of hypoproteinemia and shock. What is the main remark of this colloid is it is all an expensive than the crystalloid solutions. Synthetic colloids includes the gelatin polymers. Example of gelatin polymers is hemasil. It will be a jelly like substance like, so we will be calling it as gelatin polymers. That is a hemasil. Next is dextran compounds. So dextran polymers, it is divided into two. We have two dextran polymers, that is dextran 40 and dextran 70. Okay. Dextran 40 and dextran 70 means we have dextran 40 is around 40,000 molecular weight and 70 is 70,000 molecular weight. So why? Because these colloids have a larger molecular weight. And next is HES. HES means hydroxyethyl starch. So these are the different colloidal compounds. And mainly these synthetic colloids are used in the volume expansion. So what are the remarks behind the synthetic colloids is risk of allergy is more. So compared to crystalloid solutions doesn't have any allergy or prone to allergy, but colloid solutions have allergic reaction and coagulopathy also can be there. So these are the different colloid solutions. First you can see the albumin solution is there. So in that first image albumin is, that is albumin 5%. As I told, albumin is available in 5% solution and 25% solution. So second is, that is dextran. Dextran 40. So this 40 indicates, as I told, dextran 40 means it is a 40,000 molecular weight, as all colloids have a higher molecular weight. So another combination is also there, that is dextran 70. This is dextran 70. It contains the 70,000 molecular weight, and this is hemasil. That is gelatin polymers, as I told you. So this is polygelin or hemasil bilbitellin, and this is hydroxyethyl starch. So these are the different colloidal compounds we'll be using in our perioperative fluid therapy management. So main aim is, mainly it is used in the volume expansion cases. Okay. Next we'll be discussing the commonly between the crystalloids and colloid solution. Okay. So here you can see the crystalloids and colloids quick type. So here we can see normal saline. That is normal saline, it is mainly used for the shock and dehydration. As I told, the ongoing losses, replacing the surgical losses. So in this conditions we will be using the normal saline, that is NS. And second is hyponatremia, that is when the sodium correction is low. So sodium electrolyte imbalance is there, at the time we will be using, that is hyponatremia. It should be avoided in congestive heart failure and then renal failure cases. So main contraindications of this normal saline is, it is avoided in the CHF, that is congestive heart failure and renal failure cases. Then next is RL. RL is mainly used in the burns, trauma and surgical patients. So main aim of the RL is that it has a lactate solution. So if we take a content of a normal saline means, we will be having the Na, that is sodium and then chloride. So when we will be having a Ringer's lactate means, it will be having sodium, chloride, potassium, calcium and then bicarbonate. Okay, these are the different components present in the Ringer's lactate solution. So the choice of burns patient, the fluid choice is mainly RL. Then D5W, as I told, dextrose 5% water. So it is used in the cases of hypoglycemia. Then calories and drug vehicle. What is a drug vehicle means? We can administer the drugs through this D5W solution, and when it is not indicated as not indicated for resuscitation purposes. And in Ringer's lactate, so which is contraindicated is whenever there is electrolyte losses, that is sodium depletion or potassium depletion, calcium depletion. In that conditions we won't be using this RL. Then liver disease and acidosis. Other contraindications are liver diseases and acidosis. Then coming to colloids, as I told, it is mainly used in hypovolemia condition and then volume expansion. So we can use this colloid also for burns and shock patient. So what is the major disadvantages of this colloids are, that is it is costly. As I told, it is expensive and it is prone for allergy. So these are the major two contraindications for the colloidal solutions. So whenever we have a right fluid, right patient at the right time, will be having a better outcome. So we can see the difference between the crystalloids and colloids here. So coming to colloids, so what are the colloids we have? Already I have told you, that is albumin, dextran polymers, hydroxyethyl starch and gelatin. So these are the different colloid solutions. Coming to crystalloid solution, we have an hypotonic solution, hypertonic solution and isotonic solution. Under this only we will be having the, that is NS, RL, that is DNS, then D5W. Okay, these are the different crystalloid solutions. So colloids are the larger molecular weights. As I told, colloids comes under the larger molecular weights and it stays in the longer in the intravascular space. While seeing the crystalloid solutions, it is a smaller molecular weight. It does not stay more time in the intravascular space. So next point is, so colloids are fast and expanding intravascular space. Then crystalloids are high amount of fluid is needed to equal amount loss. See, whenever we are giving a fluid therapy to the patient, at that time if we want to give the crystalloid solution, we should be loading more amount of the crystalloid solution. Whenever we are giving a colloid solution, it is amount of how much amount of is lost, so the same amount will be replaced. That is in the 1:1 ratio will be telling, or 1:3 ratio for the that is crystalloid solution. This I will be discussing in the fluid calculation part. Okay, so high amount of fluids is needed to replace the ongoing losses. So what is the main risk of this colloids is allergic reactions will be there, and coagulopathy, like coagulation problems like coagulopathy will be there. Then in crystalloids we don't have any allergic reaction. Here edema might be present. So in crystalloid solutions, edema or fluid overload may be there. Then colloids are more expensive and crystalloids are inexpensive or cost lesser than the colloidal solution. So these are the major difference you should know between the crystalloids and colloid solutions. So next, coming to assessment of fluid status. So how to assess the fluid status? So when we are going to give the fluid to the patient, means what and all we have to assess the, so first mainly we have to assess the heart rate, blood pressure and MAP. That is the cardiovascular status of the patient. Heart rate should be measured, then blood pressure, whether the patient is hypotension or hypertensive, and what is the mean arterial pressure of the patient. Then skin turgor. Skin turgor means it is the elasticity will be telling, elasticity. So here you can see this image, no? This is the skin turgor. Whether the skin is elastic, it is normal in range, so that they will be checking through the skin turgor. That is only called as elasticity of the skin. Then capillary refill. What is it? Capillary refill is, so they will be checking the flow of the blood in the capillaries. So they will be holding this end of the point of the finger, then they will be holding for at least 5 seconds. When they release, the flow should be regained. So they'll be seeing the color. So when they hold the point of the finger, at the time what happens is the blood flow will be stopped there. When they release, within the 2 seconds, the normal color should be coming back to the position. So that is only called as capillary refill time. Then urine output. So urine output also they will be measured pre-operatively, intraoperatively and post-operatively also. Then orthostatic changes, like that is hypotension, they will be telling. Orthostatic hypotension or postural hypotension. So these are the major criteria we have to assess before giving the fluid status of the patients. So next criteria is laboratory criteria. So laboratory criteria, first why we under that, first is serum lactate levels. So why we have to assess this serum lactate levels is mainly to assess the serum lactate level means it helps in to identify the tissue perfusion and oxygenation of the patient. Okay, tissue perfusion and oxygenation of the patient. So only we will be measuring the serum lactate levels under the laboratory. Next is hemoglobin and hematocrit. That is hematocrit, packed cell volumes and hemoglobin component will be measured. Then electrolyte. Electrolyte is mainly to measure the electrolyte abnormalities. Then serum osmolality levels. That is serum sodium, serum potassium, calcium levels. That and all also will be measured under the laboratory. Then third component what will be assessing is dynamic assessment. So this is a newer concept. What this comes under the GDT. GDT means goal directed therapy. That I will be explaining in the coming slides. What is GDT is goal directed therapy. Nowadays they are using a goal directed therapy to provide a fluid to the patients. So under that we have a dynamic assessment. So dynamic assessments we have pulse pressure variation, stroke volume variation, IVC diameter, passive leg raising test and cardiac output and echocardiography. What all this component means is, so dynamic is mainly pulse pressure variation. Pulse pressure is, so mainly how we will be measuring that pulse pressure is, that is PPV is equals to pulse pressure max minus pulse pressure minimum divided by pulse pressure mean. So this will be calculated into 100. So how this will be pulse pressure and stroke volume how to calculate is same formula. Stroke volume is equals to stroke volume max minus stroke volume minimum divided by stroke volume mean into 100. Okay. So this is the main thing we have to note down in the pulse pressure variation and stroke volume variation. So these two components are measured in the IBP component, that is invasive blood pressure. While connecting to the IBP monitor, we can measure all these components. So pulse pressure is, that is PP is difference between SBP minus DBP. Okay. So this is a difference between pulse pressure. So then they will be measuring this pulse pressure variation and stroke volume variation. So these will be measured in the cardiac output monitor. So only here we have mentioned the cardiac output. Then echocardiography is TEE, transesophageal echocardiography. Using that they will be measuring this TEE. Then passive leg raising test is to measure the amount of fluid, how much is going, they will be using this PLR test. IVC diameter is inferior vena cava diameter, that is measured using the echocardiography. Okay. So these are the three main parameters we will be measuring in the assessment of fluid status. Number one is, that is clinical assessment, number two laboratory assessment, and number three is dynamic assessment. Okay. Next we will be going on to the replacement of fluid losses. As I told, this first is we will be moving on to the blood loss. So how to replace the blood losses? Replace the crystalloids. So how to replace that crystalloid solution? Just for every 1 ml of blood loss, there will be a replacement of 3 times we have to replace the crystalloid solution. So the ratio is only called as 1:3. Whenever we have 1 ml of blood loss, at the time we will be giving a 3 times of crystalloid solutions. Okay, more than 3. Okay. So when there is a 1 ml of blood loss means we will be giving a more than 3 times of crystalloid solution. Coming to colloid solution, we have only 1:1. 1:1 means when there is a 1 ml of blood loss means we will be giving a 1 ml of colloid solutions. So this rule applies to all the blood loss formulas. Okay, 1:3 for crystalloid solutions, 1:3 remember for crystalloid, and 1:1 for colloid solutions. Then when there is a packed RBC, when we will be providing is if there is a more than 20% of the blood volume loss. So when patient have more than 20% of blood volume loss, at the time they will be giving the PRBCs, that is packed red blood cells. Transfusion will be there in the patient. Whenever we have a gastrointestinal losses, that is due to ongoing vomiting or diarrhea. This is the gastrointestinal losses. So there will be a sodium depletion, chloride depletion, potassium depletion. At the time we will be providing the patient with NS or KCl, potassium chloride solutions or normal saline solution. So whenever the patient is having a diarrhea, we will be providing the patients with the RL, that is Ringer's lactate solution, and then ORS, oral rehydration salts. So this normally will be having a powder form or else in a juice form. Okay. So this oral rehydration salts helps in the prevention of, that is it accumulates in the extravascular space, and then there will be a fluid in the gastrointestinal system. Then coming to third space losses, that is only in the surgery or burns. Whenever there is a going on a surgery, there will be a blood loss will be there. Then and burns, there will be a more amount of fluid losses, that is fluid depletion, hypovolemia will be there. So at the time we can replace with the isotonic crystalloid solution, that is NS and RL. We can replace when the surgery and burns is there, at the time we can replace with the NS and RL solutions. So fluid therapy in the surgery, that is overall perioperative period. What is a fluid therapy is? Mainly we have 3 phases. Preoperative phase, intraoperative phase, and then postoperative phase. In the preoperative phase, we have to correct the dehydration and electrolyte imbalances. So mainly patient will be dehydrated. Why? Because the patient is on NPO conditions, and there will be electrolyte imbalance also. It may be any kind of natremias or kalemia or calcemias. So at the time we will be using the NS and RL, that is normal saline and Ringer's lactate solution in the preoperative period. Coming to intraoperative period, we have the ongoing losses or third space losses, like blood loss will be there, surgical losses will be there. So at the time we have to maintain the tissue perfusion. So what we have to do is we have to replace the blood losses. So so with this, what and all we have to give us Ringer's lactate, normal saline, or DNS. Anything can be preferred according to the surgeries. With that, when there is a blood loss, they will be administering the blood products, or they can use a colloid solutions in the intraoperative period. In the post-operative period, we have to maintain the patient's hydration, then vitals, and whatever the losses were there, ongoing losses or it may be the intraoperative loss, we have to replace it correctly and properly. For that is replace the ongoing losses and we have to maintain the hydration. For that mainly we will be using the NS and RL, that is normal saline and RL in the post-operative period. So remember this thing in the phases of that is perioperative period. So as I told, goal directed therapy, this is only GDT. Okay, so GDT concept is a newer concept in our perioperative fluid therapy management. So GDT means it is a newer therapy, as I told. So to measure the fluid responsiveness, we have two parameters. One is static parameters and one more is the dynamic parameters. Okay, so previously they were using all the static parameters. So what are the static parameters? CVP, PaOP. What is this CVP and PaOP is? Central venous pressure. Have you heard about central venous pressure? And then pulmonary artery occlusive pressure. So that is measured using the central venous catheter or pulmonary artery catheter. What happens in the static is, these were used previously but not used nowadays. Why? Because this both parameters doesn't provide accurate fluid status. Doesn't provide the accurate fluid status. So doesn't provide the accurate fluid status. So we are not using this parameters. While coming to dynamic parameters, it is the ongoing processes where we'll be using a cardiac output monitors, then we'll be using the different parameters to measure like SVV, that is stroke volume, pulse pressure variation, and then transesophageal echocardiography, pulse counter devices. So this is pulse counter devices are flow track. This measures the cardiac output and parameters like pulse pressure variation, stroke volume variation. So these all parameters will be measured in this dynamic parameters. So nowadays all these concepts included in the perioperative fluid management, that is goal directed therapy. Whatever the amount we are aiming for the patient, that can be achieved using this goal directed therapy, that is mainly using the dynamic parameters. So about PPV and SVE, that I have already discussed in that assessment. What is the formula, where will be measuring that. So when it comes to PPV, how will be measuring that PPVs? So this is an arterial waveform. Okay, we'll be thinking this is an arterial waveform. So when this is an arterial waveform, this is the pulse pressure maximum. Okay, this is the lowest pulse pressure minimum. Okay, so like this only they will be measuring the pulse pressure. Stroke volume means this complete they will be measuring as a stroke volume maximum. This is stroke volume minimum. So like that they will be measuring and they will be apply those formula. So they will be having a normal ranges. If there is in the normal ranges, the patient is fluid responsive. If the range falls below, the patient is not a fluid responsive. So like that they will be calculating about by using the goal directed therapy. So next we will be moving on to the main calculations, that is intraoperatively how we are going to give the fluid therapies, that is fluids. So for maintenance fluids we have a formula called as Holiday-Segar formula. So we will be telling it as Holiday-Segar formula or Holiday-Segar rule. So it applies a rule called as 4:2:1. So what is that rule has? It is mainly to calculate the Hartley rate of the fluid. Okay, how to calculate is 4:2:1. Remember always Holiday-Segar formula is calculated according to 4:2:1. So what is it 4:2:1 is? So 4 ml per kg for the first 10 kg of the patient. So for example 70 kg patient comes for an surgery, how to calculate this fluid? So the next slide I will be telling you. Okay, so for the first 10 kg we will be providing a 4 ml per kg. So for the next 10 kg we will be giving a 2 ml per kg, that is 2:2 rule. Then last one is for the remaining, what are the remaining kgs we have, will be providing a 1 ml per kg. So remember this formula 4:2:1, Holiday-Segar formula for maintenance of the fluid. So we will be seeing an calculation here. How to calculate for an adult 70 kg patient. So what is the first step as I have told you is we have to use a 4:2:1 formula here. So that is 4 ml per kg per hour for the first 10 kg. So that is 4 ml per kg means for the first 10 kg we will be multiplying, so we will be getting 40 ml per hour. So next is 2 ml per kg for the next 10 kgs, that is we will be getting 20 ml per hour. So last is remaining how much kg will be having. So in a 70 kg patient, 10 is gone, 20. So the remaining is we have a 50 kg patient. So the next 10 kgs means that is the remaining 50 kgs will be multiplying with the 1. So here 4:2:1. So what is the formula we got here is 4:2:1 formula. So the remaining kgs will be multiplied with the 1. So we will be getting a 50 ml per hour. Now what we have to do is we have to add all this 40 plus 20 plus 50. So what is the rate we will be getting is, so the main rate is, so total I have told 40 plus 50, 20 plus 50. So the total hourly rate of a 70 kg patient is 110 ml per hour. Okay, for the 70 kg patient, how we have to maintain a fluid is, that is 110 ml per hour. If we want to calculate for a day, that is for a 24 hours means, multiply this with the 24. 110 ml into 24 will be getting the all over per day. That is for a 24 hours we will be providing the 2640 ml per day. That is for all over 24 hours. If you want to give for an hour, it is calculated as 110 ml for the 70 kg patient. This is the main calculation for the intraoperative maintenance fluids. Okay, so remember the formula 4:2:1. The formula name is Holiday-Segar formula. So if you want to calculate for a child, okay, now we have calculated for a 70 kg patient. So we can divide that into 3. When there is a child coming 12 kg patients, how to maintain? So we doesn't have any new formula, we will be following the same formula 4:2:1. But what here is, for the first 10 kg we will be giving a 4. For the next 2 kgs we will be multiplying with a 2. So here you can see, as I told, for the first 10 kg we will be multiplying with a 4. 40 ml per hour. For the next kg we will be multiplying with a 2. That is the next 10 kg means 2 into that is 2, that is 4 ml per hour. So as I told, no, so 4 ml per hour. Now same we have to add this, so we will be getting the hourly rate formula. So totally for an hour, for this pediatric patient will be providing 44 ml per hour. And what is the one important point we have to remember in this pediatric patient is, so the thing is, children are prone for fluid overload, so they should receive only 2/3 of the fluid calculated by the 4:2:1 formula. So for this 12 kg patient, 12 kg child, hourly rate is around 44 ml per hour. So if you want to give only, we should not give the whole 44 ml per hour. We have to give only 2/3 of this 44 ml per hour. Why? Because the children are prone for fluid overload. Okay, so here I have mentioned why we should not give the exactly what we have calculated is, children are more prone for fluid overload. So we have to avoid and only provide the 2/3 of the calculated value. Okay, so that is the first thing what we have to calculate is maintenance using Holiday-Segar formula. Next is NPO, that is pre-op deficit. How to calculate the NPO pre-op deficit is, so deficit formula is, this is the main formula of the deficit, that is maintenance rate into hours of fasting. So we know about what is NPO is, nil per oral guidelines. So every patient will be following the NPO guidelines. According to that, so how much hours of fasting the patient is having, and then what is the rate for if a patient is a 70 kg means we have 110 ml per hour. So how much hours of fasting the patient is having? So we will be multiplying with that and we will be getting an NPO deficit. So how to replace the NPO deficit is, so mainly using the intraoperative approaches. How is intraoperative approaches? So when we are calculating this maintenance rate and hours of fasting, so we will be getting an one value. So that is one form. So that will, so in that 50% deficit will be replaced in the first hour. Okay, first 50% will be replaced in the first hour. So next is 25%. So 25% in the second hour. The remaining 25% will be given over the next 2 hours. Okay, so like this only, the 100% of the fluid will be given over this. So first 50% in the first hour, 25% in the second hour, and the remaining 25% over the next 2 hours. So remember this for the NPO deficit. Now based on this we will solve one problem. So example, a 70 kg patient with 8 hours of NPO. So maintenance already we know, we have calculated a maintenance rate, that is 110 ml per hour. So what is the deficit formula? We know deficit is equals to maintenance into hours of fasting. So what is the thing we will be getting is 110 ml into 8. So what will be getting is 880 ml. Okay, so overall the deficit volume is 880 ml. So now this 880 ml will be divided into 3 things, that is first hour, second hour and the last 2 hours. Okay. So over the first hour 50% of the fluid will be given. So 880 means 440 will be given in the first hour. See, 50% means so 440 ml will be given in the first hour as I told. So then 25% in 440 25 is 220. So 25% of the fluid will be given in the second hour, that is 220 ml, and the remaining 220 ml will be given over the next 2 hours. Okay, 220 ml over the next 2 hours. Okay, this is a calculation for the deficit. So mainly, so we have to calculate the maintenance rate first. After that we have to multiply with the hours of fasting. It may be 8 hours or it may be 6 hours or it may be a 2 hours also. Okay, any hours of fasting we have to multiply with the maintenance rate. So third component calculation in an intraoperative therapy is blood loss replacement. How to calculate the blood loss replacement? So here we want a estimated blood volume, how much volume we want to be estimated, and to calculate it, that for that only we'll be needing a blood loss replacement. So we'll be having a estimated blood loss values. So EBV values will shortly will be telling. So what is that EBV values is? EBV values for an adult. In an adult patient, the EBV value will be around 70 ml per kg. Approximately we can use a 70 for the adults. So for adults EBV value we can use 70, and for the neonates we can use around 85 to 90, and then for infants we can use around approximately 80. Okay, so these all will be represented in ml per kg. Okay, so these are the EBV values. What is that? Estimated blood volume values. Okay, so how to calculate this blood loss replacement is percentage of blood loss is equals to blood loss divided by EBV. EBV we have for adults, neonates and infants. As I told, these are the different EBV values. Then it will be multiplied into 100. Okay, so this is a formula to remember for the blood loss replacement. So what is the replacement rules is, already I have told you the replacement rules for a crystalloid is 1:3. When there is a 1 ml of loss, we will be providing a 3 times of the crystalloid solution. When colloids is 1:1, that is 1 ml of loss, we will be providing the 1 ml of colloid solution. When we are using a transfusion, that is packed red blood cells, use a clinical tribers, that is we will be using the values, hemoglobin values, hemodynamics, heart rate, blood pressure and mean arterial pressure of the patients, all that will be measured in the hemodynamics. By using this they will be providing the transfusion. So what is a rough guide here is, when we administer 1 unit of packed red blood cells, it is considered as, or it raises the 1 gram of hemoglobin in the adult. Approximately when we transfuse 1 unit of packed red blood cells, there will be an approximate 1 gram of rise in the hemoglobins. So remember this in the replacement rules. So that is 1:3 formula, 1:1, 1:3 for crystalloids, then 1:1 for colloids, and PRBCs, that is PRBCs, what you have to remember is, when we transfuse PRBCs, approximately 1 gram of HB will be raised. Okay, that is 1 unit of PRBC when we administer, there will be a rise in 1 gram of hemoglobin. So these are the 3 rules you have to remember in the blood transfusion. So we will be calculating a blood loss replacement for this patient. So we have an 70 kg patient and the 500 ml of blood loss. Okay, so first we have to calculate the estimated blood volume. So EBV values as I told. So for EBV value is 70 kg. 70 kg is an adult patient. Adult patient means we will be using approximately 70. Okay, so that is 70 ml per kg EBV value into 70. So when we multiply this, we will be getting a 4900 ml. So now EBV value for this 70 kg patient is 4900 ml. So next what we have to do is, we have to substitute this in the formula, that is a percentage formula. Percent loss is equals to, what is the formula was, that is percent loss is equals to blood loss divided by EBV into 100. So this was the formula for calculating the blood loss replacement. Here what is the amount of blood loss? 500 divided by, what is the EBV value we got? 4900. When we both divide this, so we will be getting a value around 0.102. So now 0.102 when we multiply with 100, we will be getting a value of around 10.2. So 10.2 2% of blood volume is lost. Okay, so this is a way to calculate the blood loss volume. Okay, so in this patient 10.2% of blood volume is lost. So what is the now thing is we have to replace. So how to replace this? That is, as I told, we have to use the ratios, that is 1:3 for crystalloids and 1:1 for colloids. So what is the thing is, so here 500 ml of blood is lost. Okay, so we have to replace it 3 times. So that is 500 into 3. So we will be getting a 1500 ml. So for this patient we have to administer 1500 ml of crystalloids. We will be using this ratio 1:3 ratio. So here 500 ml of blood is lost. When we are going to administer colloid, we will be administering the same amount of colloid because of 1:1 ratio. 500 ml of blood is lost, 500 ml of colloid is administered to the patient. So this is a way to calculate the blood loss and replacing it with the crystalloid or colloid solution. Always remember in the replacement rules, as I said, 1:3 for crystalloids, 1:1 for colloids. So coming to stepwise checklist when calculating the fluids. So what is the checklist we have to maintain is, first I have told you maintenance fluid, that is holiday sick formula. Next is NPO deficit, maintenance rate into hours of fasting or hours of NPO. Next, third is ongoing losses also we have to add, that is suction loss, drains, then diarrhea, estimate and replace. Then third place losses, what are the third place losses is, that is surgeon guidance, that is during the surgery or burns. So these are the third place losses. Okay, then add the blood replacement. So blood replacement is, that is using the 3:1, sorry 1:3 or 3:1, then 1:1, 1:3 for crystalloids and 1:1 for colloids. Then we have to choose the fluid type according to the tonicity or based on the phases of the perioperative management, that is RL versus NS based on the electrolytes and acid base disturbances. And finally we have to monitor the patient's BP, heart rate, urine output. This is an important thing what we have to monitor, okay, in the post operative phase also. Okay, urine output should be almost more than 0.5 ml per kg for the patients. Okay, so always remember urine output while giving a fluid status or measuring a fluid status. While monitoring, you have to remember heart rate, that is hemodynamics will be monitored, then urine output will be monitored. Urine output should be more than 0.5 ml per kg. And lab values like, that is lactate, then electrolytes, then hemoglobin, then so these are the different lab values we'll be using there, then adjusting according to the vital signs. Okay, so these things you have to remember while giving a fluid therapy to the patients. So fluid therapy for special situations. So as in special situations mean burns. For burns we are not using this same formula, that is 4:2:1. We are not using this. So instead of that we'll be using a formula called as Parkland formula. What is it? Parkland formula is, it was introduced by Parkland. Okay, so formula is 4 ml into kg, that is body weight, into percentage of TBSA. What is a TBSA is? Total body surface area burnt. Here it's there, no, total body surface area burnt. So what is the total body surface area burnt is, how much percentage of body is burnt. It is calculated according to rule of 9. Okay, this TBSA is calculated according to rule of 9. So it will be divided into percentages for a head, neck, then trunk, abdomen, thorax. So each thing will be having a percentage which covers the 100%. So that percentage will be calculated using this TBSA, that is total body surface area, will be calculated using rule of 9. You have to remember this. Then the formula for calculating in the burns patient fluid is 4 ml into body weight, that is in kgs, into percentage of TBSA. So for example, a 70 kg patient has a burn, that is 40% of TBSA burn. How will be the formula is, that is 4 into, then what is the body weight? 70 into percentages 40. So first you have to calculate 4 into 70, then multiply with the 40. So 4 into 70 we have got 40. So then, so that is 280 into 40. So what is the thing we'll be getting is, so when we calculate all this thing is, so we'll be getting a 11,200 ml. Okay, so the overall fluid for this patient will be 11,200 ml. So how you have to administer for this patient is, here you can see That is mainly what is the choice of fluid is RL. Why RL? As I told, indications. So in indications of Ringer's lactate, the choice of fluid in burns is Ringer's lactate, that is RL. So how this fluid will be calculated for the patients is, so this 11,200 ml means, so for the first 24, so for the, this is for overall 24 hours. So for the 24 hours 11,200 ml. So how we have to provide this to the patient is half in the first 8 hours, other half in the next 16 hours. That means 5,600 ml in the first 8 hours. Then the remaining 5,800 in the over next 16 hours. In a 24 hours, first 8 hours will be providing 5,800 ml. After completing that, so for the over next 16 hours will be giving the 5,800. So remember the Parkland formula and then how to provide the fluid for the patient. So Parkland formula is 4 ml into kg, that is body weight into percentage of TBHA. So how they will be providing fluid is, that is it will be calculated for the 24 hours. So that 24 hours will be dividing into two things. So for the first half will be given in the first 8 hours, the remaining half will be given over the next 16 hours. So this is to calculate on the burns cases. So just one case scenario will be solving. Okay. So adult 55 kg patient, 8 hours of NPO, minor blood loss, that is 300 ml. What number of crystalloids is required? Okay. So what we have to calculate here is maintenance we have to calculate, deficit we have to calculate, and what is the replacement of the blood loss. Okay. Maintenance how we will be calculating using the 4:2:1. Deficit is, that is maintenance into NPO. Replacement is, that is for crystalloid solution means 1:3 we have to remember here. So using these three components we will be solving this. So first is maintenance. How we will be calculating maintenance is similarly. So that is 4 ml, then 2 ml, then 1 ml into 55 kg patients, no. So 4 into 10, 2 into 10, so remaining will be 35. So we will be getting, that is 40, 20, then 35. So totally we will be getting 40, 20, so total this is 95 ml per hour. Okay, that is a maintenance fluid requirement for this patient. Now how to calculate NPO? That is 95 into 8. So what will be the value is, that is 760 ml. Okay, how to replace this 760 ml is, so first half will be, that is 50%, so 760 half is 380. So 380 will be given in the first first hour, the remaining will be given over the next, so for the next 2 hours and the remaining 2 hours, 25% and 25%. Okay. So for blood loss replacement we will be using the 1:3 ratio formula. So 1:3 means, that is we have a 300 ml of blood loss. So 300 ml means, so we will be giving the 900 ml. Okay. So 3 times. Okay. So what I told is, when there is a 1 ml of blood loss, we will be replacing with the 3 ml of crystalloid solution. Similarly, we have 300 ml of blood loss here. So we want to replace a 3 times, that is 900 ml of crystalloids will be provided for this patient. Okay. This is a way to calculate the maintenance fluid requirement, deficit formula, blood loss replacement, and then the ratios of the blood loss for the crystalloids and colloids. Okay. So total early introp requirement, that is how to give us deficit replacement we have to replace, that is deficit replacement plan. Then 900 ml is the overall fluid. So we have to adjust with the signs, that is clinical signs, whatever we are monitoring, we have to adjust the fluid according to the clinical signs. So in the post-operative phase, what and all we have to do is, so that is fully about the intraoperative phase. In a post-operative phase, we have to continue the fluids until oral intake is adequate. That is when the patient is, overcoming the NPO status. Okay. When the patient is shifted to the PICU, at the time also they will be continuing the IV fluids. Okay. Then maintenance rate will be around 1 to 1.5 ml per kg per hour. Then monitor the signs. As I told, urine output 0.5 ml per kg, mean arterial pressure, that is hemodynamically it should be around 65 mmHg. If there is any central line, we have to monitor the central venous pressure and then heart rate. Lactate clearance. So lactate, why I told, lactate we are measuring because mainly it identifies the tissue perfusion and oxygenation, then daily electrolyte requirements. These all things we have to monitor in the post-operative period. So what are the indications for post-operative IV fluids is, NPO status we have to see, then hypovolemia. If the patient is low level or volume depleted, ongoing losses also we have to see. Whether the patient have drains, any surgical drains like intercostal drainage tubes or any suction drains. So and Rayleigh tube, that is NG tube is feeding tube. and drains. Okay, these are the ongoing losses. Through this, whatever the losses is there, we have to replace. And sepsis or hemodynamic instability. So when the patient is having sepsis or hemodynamically unstable, that is hypotension or hypertension, any tachy or bradys, it's there. At that time, we have to administer the fluids. Okay, so these are the things we have to take care in the post-operative phases. So finally, we'll be moving on to the complications of fluid therapy. So what are the complications we face while giving a fluid therapy? So first complication is fluid overload. As I told, fluid overload in the cases is, so we'll be administering normal volume. If we administer, there is no problem. So when there is a excess, that causes an overload. Okay, that is excess infusion. So we are calculating one rate, but while giving, we will be giving a more amount of fluid. That causes the excess infusion. So what effect it occurs is, there will be a pulmonary edema and congestive heart failure will be there in this fluid overload cases. Okay. Next is electrolyte imbalances. In electrolyte imbalances, we have to give the electrolytes actually. Okay, so we'll be choosing a wrong fluid choice. Okay, if we choose a wrong fluid choice, what happens is there will be a hyponatremia, hyperkalemia, all again electrolyte disturbances will be there. So third is acid basis disturbances, that is like metabolic acidosis or alkalosis, then respiratory acidosis or respiratory alkalosis. So these are the metabolic disturbances or acid base disturbance. When there is there, so normal saline if we give in those cases, so there will be a hyperchloremic acidosis. Okay, this affects the renal system. Okay, hyperchloremic acidosis. So what happens there is, there will be an alter in the pH. For the acid base disturbance, there will be a normal pH value range, that is around 7.35 to 7.45. So when we give this NS, there will be hyperchloremic acidosis, there will be an alteration in the pH. So the patient will be having a normal pH. At that time, what happens is the pH will be altered, the pH will be abnormal. It may lead to acidosis or alkalosis condition. So that is called as altered pH. Then allergic reactions. Allergic reactions in the case of colloids, as I mentioned in the colloids topic. Then there may be when there is a colloids, there that is allergic reactions, there may be hypersensitivity reactions and anaphylaxis reaction, that is allergic reaction. All these are allergic reaction. Then coagulopathy. Coagulopathy is also one of the that is a disadvantage of the colloids. When we give a large volume of colloids, there will be a coagulopathy in the patients. So which dilution of clotting factors. So these are the major complications we'll be placing in the fluid therapy. Thank you students for listening my class.